All right, guys, it is 2:05, and we'll be letting more participants in throughout the seminar. But for now, we're just going to start with our introduction. So if you don't know, we are Advocate for Lives, a youth-led organization that raises awareness about blood donation, organ donation, as well as health-related research. And before we start this presentation, we just want to go over some housekeeping rules. So first of all, please do not spam the chat and keep any messages in the chat relevant to the seminar. And as always, no swearing or inappropriate language. Please mute yourself unless otherwise asked to speak by the speaker, or if you would like to add anything in. And this session will also be recorded. You probably got a notification of that as well. And we just do that so that we can post it on our YouTube channel for anyone to watch them again in the future.
Yep, so now that that's out of the way, let's get to the reason why you guys are all here. So today we're going to be talking to Dr. Gilberto, who's an emergency medicine physician, as well as the medical director of UT Southwestern's Virtual Clinical Observation Program and medical director for Hutchins Fire Department, as well as much more. So we will be addressing all of the questions asked through the Google Forms, as well as in the chat at the end of Dr. Gill's presentation. So without further ado, Dr. Gill, please take it away.
Well, good afternoon, Advocate for Life. It is a pleasure to be here today. Saturday is my second favorite day of the week. Friday is probably number one, but Saturday is number two. That's one of the days where I'm the most productive. And so part of being productive today is reaching out to my young friends and my pre-healths. A couple of things about this presentation. I want you to know first and foremost that the reason I'm doing this is because I firmly believe that, you know, we get called healthcare heroes a lot, and there's banners and all these accolades, right? Because of the work that we're doing in COVID-19. But the reason I'm really doing this is because I also want to honor you, because your contribution with this pandemic is equally as valuable, if not more valuable than what I do in the front lines against COVID-19. I'm doing my job, and I do it with pride, and this is what I train a lifetime to do, and it's a privilege to be of service. But by the sheer fact that we are here talking virtually, getting to know folks from around the world, you guys staying home and doing the right thing and preventing the spread of COVID-19, you guys are really valuable to this effort. So I'm doing this as a way to honor you, and I hope that you know that I'm seeing you, I'm watching you, and I really appreciate the work that you do by staying home. That makes my job easier. And it also helps you keep you safe. So this is my way to honor you. Today's talk is going to revolve around my life here the last several months since the pandemic started. A lot of folks have questions about what COVID-19 is and how that relates to what I do for a living. And a lot of people have questions about what happens in the front lines against COVID-19. So this is a way for me to kind of share my experience with you, teach you guys a couple of things, get you guys excited in your path to being a clinician. And I welcome all pre-meds, pre-PAs, pre-nursing. I am very familiar with pre-health education as the medical director for Virtual Clinical Observation Program, and I'll put in a little plug there at the end. Okay. The second thing is, this is going to be an engaging talk. This is not going to be a one-way street. This is not a podcast. I really like small groups because we can really get some interaction going. I want you guys involved. I want you guys engaged. I want you guys asking questions to make my time productive and your time productive. We're going to be launching some polls during the presentation. Once we get to them, you'll figure it out. It's pretty easy, but I'm going to test a little bit of your clinical knowledge and teach you guys a couple of things. Okay. The overarching theme for this presentation is captured very nicely, I feel, with the first slide. Okay. If there's one thing that I want you to learn today, is that a career in medicine, no matter what specialty you're in, what discipline you're in, or what field you're going into, I'm here to tell you that your career in medicine has to be first and foremost focused on service to other folks. You can be a really good clinician and do great diagnostics, be a good proceduralist, and have great skills in doing things. But I'm here to tell you, if you're going into medicine for the accolades, for the money, for the glory, or for the procedural skills only, you're going to your career is going to be cut really short. Burnout is a real deal. However, if you embrace empathy, if you embrace service and sacrifice to others, your career is going to be long, and you're going to be remembered very well in the halls of the House of Medicine. This picture was taken on a Sunday afternoon, my only day off that week, and my phone went off, and it was a dear friend of mine who also doesn't live too far from me. He called me because he was having some difficulty breathing and he was having some chest pain. Basically, his question was, do you think I should call an ambulance? Well, I told him, I don't live too far from you. And I thought to myself, I have the skills and the knowledge, and I spent all that time training a lifetime to be of service to others and to sacrifice for others. The right thing to do is to pick up my doctor bag, my little go bag, and go help my friend and take a look at him. So yes, I left whatever I was doing on that Sunday afternoon, got in my car, and went to take care of my friend. And he was doing okay. I tell you that because I could have just told him, yeah, call an ambulance. Cool, call it a day. But that's not what being a clinician is all about. Being a clinician is a life of service, of sacrifice, and I hope that you guys always remember that. So let's get rocking and rolling with the presentation. I'll tell you a little bit about my career path. I was born in Guatemala, a beautiful country in Central America. We came to the United States when I was 10 years old. We quickly integrated ourselves into the culture. I didn't speak really any English at all, and as a kid, you pick it up really quickly. And we made the best that we out of it as we possibly could. I didn't really even think about it at the time, and as a kid, you don't really think about it. But we were dirt poor. We lived in a 2-bedroom apartment. There were 6 of us kids, my siblings, my 2 parents, and a nanny who immigrated with us to the US. And as a kid, you just think life is what it is, and you enjoy it, and you go to school and you do your homework and you try to be good with your parents. You don't think about how much my parents struggled. I tell you that because one of the things that helped push me along in my career was the generosity and the kindness of individuals who facilitated me going to one of the premier high schools here in Dallas. We could have never afforded it. It was through this individual's kindness and generosity that I got a scholarship to go to Jesuit College Prep. I excelled in high school. I worked during the summers to help pay for my tuition in addition to my scholarship. And I was very fortunate to have a very, very generous scholarship to Vanderbilt University, where I did my undergrad and got my bachelor's in neuroscience. I had always had an interest in medicine, going back to my young days as a young boy growing up with my grandfather, Dr. Antonio Berrios. And if you haven't heard that story before, please jump on YouTube. My virtual shadowing session from September 22nd kind of details some of those things. But to make it short and sweet for you, I took I call it an advancement year. I don't call it a gap year. It makes me feel like, well, like some gap in your life, like you did nothing. It was actually a very enriching year for me. I worked in a hospital in Florida after college, got to work with a neurosurgeon actually, and he really pushed me along. And that's when I really solidified my decision to go to medical school. I was fortunate enough to go to my first choice as UT Houston Medical School in Houston, Texas. I fell in love with emergency medicine as a specialty, and I was fortunate enough to match into a residency at Louisiana State University, LSU in Baton Rouge, right around Hurricane Katrina in 2005. because of my experiences with dealing with the aftermath of Hurricane Katrina. I fell in love with the subspecialty in emergency medicine, which is called Emergency Medical Services, EMS, dealing with pre-hospital medicine, ambulance service, transport, law enforcement, disaster, everything that happens pre-hospital. I fell in love with it. In a little bit, I'm going to tell you a little bit about my career in EMS. I got a job here in Dallas for my fellowship, as a 2-year fellowship, and I was asked to stick around as full-time faculty for the Department of Emergency Medicine at UT Southwestern, where I serve as an associate professor. So unbelievable that it's been 11 years. I consider it a marathon. I'm still going. I don't know when the end is coming. I'm still having a lot of fun, finding new things, new exciting folks to meet. And part of my being here today is engaging new friends from all over the place, overseas and abroad, and our neighbors in Canada, just north of us. So very happy to be here. Okay, now that we can dive into into our presentation, I'm going to engage you on the first poll, and it's very easy. You can do it on your laptop or your phone. You can go to that website, pollev.com/ put in my first name, then SALA511, and that allows you to engage with the poll. And so I just want to get a baseline knowledge of how good your understanding is of what happens on the front lines of COVID-19. And there's no wrong answer. There's no right answer. I've done this presentation a few times, and I get number ones and number fives. If you can't access the technology, then put it in the chat. I just want to see kind of where you sit in all of this. So let's see. I'm getting a 3. Let's see, a fair. Okay, that's good. Thank you, Nikita, for putting that in the chat. Let's see what else you guys got. Let's see any 4s or any 5s. Let's see what we got. About a 4. Okay, 3 or 4. That's pretty good. Fair is good. So my hope with this talk is to bring those of you who are a 2 or a 3 to bring you to a 4 or a 5. And those of you who are a 4 or a 5, you might be surprised to know you might actually be around a 2 or a 3. So I want to get you guys all around a 4 or a real 5 at the end of the day. So thank you for engaging me on that poll. Let's start with really what the front lines are, what it looks like, what my responsibilities are. I'm an emergency medicine physician. I deal with anything that comes through the door. It doesn't matter what it is, what time of the day it is. We see it all. And I'm trained to handle any emergency that comes to the door. So patients with a myocardial infarction, which is a heart attack, or patients with a stroke or trauma, gunshot wounds, stab wounds, motor vehicle collisions, you name it. That's what I'm trained to handle. What was interesting is that, in December of 2019, when we started hearing about this novel virus and that popped up in the Wuhan province in China, we started hearing about it and how contagious it was and how much the province was struggling. And, you really didn't think it was going to affect you. We were just doing exactly what we've been doing for many, many years. Okay. Never in our wildest dreams could we have imagined that it would definitely come through our doors. On February 28th of 2020, I received my very first patient whom there was a possibility of COVID-19 in Dallas, Texas, as early as February of 2020. Unbelievable. This gentleman had been traveling in Asia. He made a stop in Japan and spent some time at the airport. And he developed some sore throats, a little bit of malaise, some body aches, and he made his way to Dallas. He came to the hospital and checked into our emergency department to be seen. Ladies and gents, I'm here to tell you that we have trained a lifetime for this, but nothing really prepares you for it. I have to admit that there was a little bit of excitement in my brain. There was a little bit of jitteriness, a little bit of nervousness. But at the end of the day, my resident Ty Standard and I, we said to each other, Ty, this is what we have trained a lifetime to do. We're going to do our job. We're going to go put on our PPE and we're going to go take care of that patient. No fear, no concerns about anything else other than doing our job. Okay. You're going to notice here what our personal protective equipment looks like. And I'm going to point out a couple of things in my picture right there. And all of these are available on my Instagram account, by the way. I'll put that at the end. I am wearing an N95 mask. We know that SARS-CoV-2, the virus that causes COVID-19, is a aerosolized virus. And so my baseline mask is an N95 mask. On top of that, I have a surgical mask, which gives me an additional layer of protection. You can't see it, but I have a second layer there. And then I have my face shield that also features a kind of a surgical mask component. So that is my third layer. Okay, that is pretty good protection against COVID-19 and its aerosolized fashion. I am also wearing an impermeable gown because we know that SARS-CoV-2 and its droplets can be transmitted fairly easily. They can get into places you don't want them to. And so I'm going to wear my gown each and every time. I also have 2 layers of gloves, one inner layer and one outer layer. The inner layer is my safety layer, just in case something happens with my outer layer. And it also helps me take off my personal protective equipment, my PPE, a lot easier if I'm wearing 2 layers. Notice I'm wearing a surgical cap. I don't normally wear a surgical cap because I don't work in the operating suite. But with COVID-19, that is not something that I want on my hair. Yes, of course, I shower when I get home. But during my shift, I don't want any droplets or anything on my hair. I can just take that off at the end of my shift, put it in the washer or a bag, and I'm ready to go. You'll also notice those signs there to my right on your left-hand side. You got a droplet isolation, an airborne isolation, and a contact isolation. When I see a room with a patient room with one of those or all those 3 signs, chances are pretty good that I'm about to go see a patient with suspected COVID-19, and I'm going to gown up each and every time to take care of business. So I do still have to see that patient, no matter what the chief complaint is, and whether it's trauma or whether it's a heart attack or whether it's a stroke. Those of us in the front lines have to take care of ourselves so we can get home safely, keep our families safely, and we can come back to serve more patients. What's scary about COVID-19 is that you can have asymptomatic patients, and because of that, even patients who have no symptoms whatsoever may come in for something completely unrelated. We still make them wear a surgical mask, and that is required. There are no exceptions. And I'm going to wear my PPE as consistently as I possibly can. Okay. I tell you all of that because that is one of the reasons we keep young learners away from hospitals. That is one of the reasons why you guys are not being allowed in hospitals and why we're doing this virtually. We want to keep you safe. Our PPE, our supplies can run kind of short. And so the last thing we want is for young untrained learners to be walking in there and exposing themselves and using a PPE. Okay. So once again, the work that you guys are doing from home helps us take care of our patients even better. All right. Okay, let's dive into a little bit of a case, and these are real cases. And I know that these cases are going to be posted online and on YouTube, and I try to de-identify them as much as I can. And I would like these cases to be as well, to honor these patients whom I took care of. So let's start by telling you that I was tasked with seeing a 71-year-old gentleman, history of diabetes, Spanish speaking, with chief complaint of about 2 to 3 hours of kind of difficulty communicating with his family. Okay, just a little bit confused, not acting quite himself. As the family is trained to do, they checked his blood sugar, making sure that he was not hypoglycemic or low blood sugar. It was normal, so they decided to bring him in. On our physical examination, his blood pressure, he was hypertensive. It was a little bit elevated. His heart rate was normal, temperature was normal, respiratory rate is normal, and his oxygen saturation by pulse oximeter on his fingernail was 97%. I performed a neurological exam, which was pretty much unremarkable. So as you digest that information, let's see what you young clinicians think. And remember, you are a clinician and you're thinking about a diagnosis for this patient. So are we dealing with hypoglycemia or low blood sugar? Are we dealing with a stroke? Are we dealing with psychiatric emergency, or sepsis, which is a manifestation of severe infection? What do you guys think? Will I take a swig of my water? All right, looks like low blood sugar. All right, anybody else have any other thoughts about what could be causing this gentleman to have difficulty with speech and some confusion? Could we be dealing with a psychiatric emergency, or is the infection getting more significant, more disseminated? See, stroke is making a little bit of a comeback. Okay. All right. Good deal. You guys are smart. Let's see what we got. As part of any evaluation for a patient with stroke-like symptoms or a neurological complaint, we sometimes obtain a computed tomography, which we call a CT or a CAT scan. And that's going to be on your left-hand side. So what you're seeing there is a cross-section of the patient's brain. And so you got to pretend the patient's feet are closest to me and their head is farthest away from you. So you're on your left, that's the patient's right. On your right, that's going to be the patient's left. Okay. So you see on your left, on the patient's right, you see that deficit there at the bottom looks black, and you don't see that on the other side. Kids, that is evidence of a stroke, okay, which can help explain some of the patient's symptoms that brought him in. And as part of our workup, we also do a 12-lead electrocardiogram to look at the electrical conduction activity of the heart. And you see right there in those leads, they're called V1, V2, and V3. You see that peak that goes up and then comes down. Okay, those are called the T waves, and those signify repolarization of your cardiac cells. Okay, whenever we see some of these things, we start getting concerned about a patient having what's called a myocardial infarction or a heart attack. All right, this was the first time that I saw it in person. And what I'm talking about is something that I had only read about in the literature, COVID-19, and that is the phenomenon of seeing the hypercoagulability and increased likelihood of clotting for patients. Okay, and we believe it's an effect of COVID-19 and its inflammation of the blood vessels, etc., leading to excessive clotting. Okay, when you clot off your vessels to the brain, to the heart, on the vessels that supply your lung, etc., you can have clotting. So this patient had both a stroke and a myocardial infarction. Okay. Ladies and gentlemen, I admitted this patient to the intensive care unit, where he died within 24 hours of my seeing him. Okay. I was involved, and I was involved in notifying his wife of 48 years that her dear husband had died. For anybody around the world who has any doubt about how devastating this is, I wish they could have been there and hear her sorrow and feel her pain when the person most important in her life was gone, and mostly with COVID-19. Okay, so I want you to remember, I hear a lot of rhetoric about the survival rate, etc. When it's your own family member, or when you have to notify them that their loved one has died or has had a bad outcome from COVID-19, it hits a lot harder. Don't let anybody tell you otherwise. And I will fight to the very end to tell you that COVID-19 is absolutely devastating. And if you don't believe me, then this family can tell you everything there is to know about how devastating it is. Just Jasmine wants to know if the neurological exam was okay, what made you think it's a stroke? Jasmine, thank you for your question. One of the main tenets of a clinician, and one of the reasons you go to school for so long and you train for so long, is because nothing in medicine is always black and white. There's always that gray area. Okay. And so when you tell me a diabetic patient comes in who has kind of an abnormal speech, some confusion at home, and I've checked a lot of things and those things are coming back okay, one of the things that can do that is a stroke. Okay. And so, Jasmine, I tell you this to encourage you, because in the books you're going to say, well, a patient with stroke is going to have X, Y, and Z. Jasmine, I'm here to tell you, patients with stroke don't always have X, Y, and Z. They might have A, B, and C, only B, sometimes none of those. And your clinical acumen, which we call it, okay, kind of your spidey sense as a clinician really kicks in. All right. And that's why you train a lifetime for this. And I do this to encourage you to keep going. All right. Thank you, Jasmine, for your question. All right. So that is case number one. I told you about kind of the front lines of COVID-19 in my clinical work, but people always ask me, what does being a professor at a university, at a medical school really looks like? Okay, so let's start with the picture on your left. That is me with second year medical students at UT Southwestern, teaching them advanced cardiac life support. That was also on a Saturday. Okay. I showed you this picture because when you work in academics, like I do, many of my day-to-day responsibilities are teaching pre-health students like you. I also teach nursing students, physician assistant students, medical students. I teach my physician residents, etc. Okay. I even sometimes even teach other faculty. And the sacrifice that I made that Saturday to go be with this group is to go teach emergency cardiac care. Okay. I also give these kids credit because they're the cream of the crop. Someday you guys are going to be in their shoes. And believe me when I tell you, they sacrificed a lot to be there. Okay. They gave up a lot. They made the cut. They're the cream of the crop. They're elite students, and they are being rewarded right there by being given the opportunity to learn life-saving skills. I show you that picture so I can encourage you to keep going, because someday you're going to be in their shoes, and that road is not easy. It's a tough road. Okay. On your right, we spoke a little bit about EMS. One of the things that impassioned me about EMS when I was in residency, I learned the following lesson. The hospital is a relatively sterile environment compared to some of the other places that you have to deliver medicine, okay, and provide care. So when I was a resident in emergency medicine, we do a rotation basically with EMS. And the thing that attracted me the most about EMS is the delivery of care in places that are austere, not the best of places, sometimes on the side of the road, on a ditch, in the dark, sometimes when gunshots are going off a couple of feet from you, or when a big fire is destroying a home just right down the street from you. And you're also delivering care in one of the most sacred places in a patient's life, and that is their own home. For a patient to invite you into their home because they're so sick that they call you and they invite you into their home to take care of them, it's an absolute privilege and an absolute honor. And I took that privilege very seriously, and that made me want to learn how to deliver care in places where you don't have all the resources or a big team, okay? You have to learn how to be resourceful, how to think on the fly, how to utilize emergency equipment. And one of the most fun things about my job as an EMS doctor is that an EMS physician like myself, whenever you call an ambulance service like you do in Canada or in the United States, you call 911 and a paramedic or an EMT comes out. When they deliver care, they work under the license here in Texas, for example, of a medical doctor, okay, who helps them develop their clinical protocols, their guidelines, and help them take care of that patient. All right. I serve as the medical director for Hutchins Fire Rescue. It's a small city just south here of Dallas. And when I spend time with them, well, it's a fire department. So not only do I help them with their medical care, I also have the privilege and the opportunity to be a firefighter with them. So I'll go jump on the fire suppression apparatus on the engine or a fire truck. It will go run some calls, and it could be a fire alarm. It could be an actual fire. It could be an accident on the side of the road. It could be a medical emergency. My brothers and sisters at Hutchins Fire Rescue treat me like one of their family. I treat them as such as well, and it is an absolute blast. I tell you about this because being a physician affords me the opportunity to do some things that not a lot of people in the world get to do. And I've spent a lifetime training for it, and I show this to you to encourage you. And if someday you want to take my job and you want to do this, well, when I'm retired in a cabin, maybe somewhere a snowy part of Canada, that would be cool, by the way. You guys got to put in the work now, make the sacrifices now. And someday you can be in my shoes. Okay. All right. Let's talk about case number 2. This is a 31-year-old woman with no past medical history. She comes in with shortness of breath, fever for almost a week. And when you get a little more history, she tells you that right around the holidays, right around the 4th of July, she had attended a pretty large gathering, a lot of it indoors, no masks, nobody sick to her knowledge. When you start getting some information, you note that her blood pressure is low. You note that she is very tachycardic. That means a fast heart rate. You know that she's got a fever and her respiratory rate is very high. Normally, it should be between 12 and 18 breaths per minute. She is at 26 right now. Her oxygen saturation, you remember the last gentleman, it was 97%, which is normal. Hers is an abysmal 72%. Okay. Anything below 92 to 94% is concerning. Hers is 72. All right, so let's see what you guys wanna do here. I am gonna give you a little bit of a hint. Okay, this is a chest X-ray right here. I'm gonna walk you through it right quick. So a couple of things to remember: on the sides, on the thorax, on the chest cavities to your left and your right. Okay, you have lungs which are filled with air, and air should look black in an X-ray. Okay, in the middle you have the heart silhouette right there, which is normal. You have the aorta silhouette, which is normal. Pretty much everything there looks pretty normal, but you see there at the basis of the patient's lungs. Okay, you see that cloudiness, that haziness right there. Ladies and gentlemen, that is a chest X-ray, very concerning for somebody with fluid in their lungs. Okay, with that history that I just gave you, and with this chest X-ray, I don't need a nasal swab to prove to me that this patient is suspected of having COVID-19. Okay, this is what COVID-19 does. It affects a lot of organs in your system, and one of the hardest hit is your lungs. It creates a bad inflammation of your airways. It starts creating fluid in the little pockets in your alveoli, they're called, in your lungs. And that is one of the reasons why patients with COVID-19 can develop shortness of breath. They develop cough, chest pain, they develop fevers, they develop fast heart rates, and most concerningly, they develop low oxygen saturations. Okay, for anybody who wants to minimize COVID-19, I would love for them to interview this patient and ask her just how well she felt. Obviously, she did not feel very well. Okay, so you young clinicians, let's see what treatment you want to give the patient. What is the first step in management? Is it intubate the patient and place them on a ventilator? And intubation means putting an endotracheal tube in the patient's trachea. You want to administer some oxygen, high flow through a nasal cannula right there. Do you want to give the patient some antibiotics and start them on some IV fluids perhaps? Or maybe take a look at her, discharge her home, and on some antibiotics. What do you guys want to do? I'm seeing a little bit of high flow oxygen here. All right. Any other takers? Her low O2 saturation is pretty concerning. Nobody wants to intubate this patient. No takers. Oh, there we go. Okay. All right, let's start discussing a little bit about this patient. One of the hardest things about working in the front lines against COVID-19 is just the sheer number of these patients that arrive on a day-to-day basis. And you only really need to take a look at their vital signs and their chief complaint, that even before you see them, you know what you're dealing with, okay? When you see patients like this lady, one of the hardest decisions on the front lines is how to best help them in the midst of bed shortages in the hospital. And even more concerning, you can have all the beds, hospital beds in the world. You cannot train a physician or a nurse or a respiratory therapist or a technician overnight. We need the personnel to staff those beds, and that's not something that we have the luxury of having extra of, okay? So with somebody with this low of an oxygen saturation, a lot of the times we're going to actually be very aggressive and actually intubate these patients and put them on a ventilator, okay? However, you got to remember this. One of the hardest decisions is, if I put this patient on a ventilator, that pretty much commits them to a certain type of bed in the hospital, namely an ICU bed, an intensive care unit bed. And those are very precious commodities. And the staff is even more short in many hospital systems, okay? So what we have learned to do is actually figure out other ways of helping the patient with their ventilation, it's called, and their oxygenation, especially by doing other things like administering high flow oxygen. Okay, high flow oxygen is a nasal cannula, little prongs in the nose, and it's delivered at a high rate, and it is moisturized and heated so that it's a lot easier on the airway passages in your nose, for example. Okay. And what that does is actually buys us a little bit of time to allow the patient to try to get better on their own, perhaps with a little bit of medication such as steroids, and hopefully not have to put them on a ventilator. Okay. I apologize. I don't want to hurt anybody's feelings or bring back bad memories. If you've had family members who died with COVID-19, who may have been on a ventilator, it is the truth that when you have to put somebody on a ventilator with COVID-19, that means that they're doing pretty poorly. And I have friends, I have had colleagues, I have had parents of some very dear pre-healths who have died with COVID-19 or who've been on a ventilator. So we do everything we can to try to get them a little bit better with high flow oxygen. Sometimes they'll need some antibiotics. Sometimes they'll need fluids. They won't be discharged home if they have an oxygen deficiency like this patient. I want to tell you that one of the struggles with COVID-19 is a shortage of blood, okay? Because of the pandemic, many folks are concerned about blood donation. They don't want to be exposed. They don't want to go to a donation center. And additionally, we also use parts of, and the necessity for blood is always going to be there. There is always going to be folks who require blood transfusions, for example. So for our friends at Advocate for Life, I want to make sure that you guys know that blood donations are always needed and encourage members of your community to donate blood. A lot of patients with COVID-19 wind up needing organ transplants. Some of them need lung transplants, for example. Okay, so I'm also advocating today, if you have never thought about donating organs, that is something that is very much appreciated, is giving life back to somebody who needs it. I myself, I will be an organ donor, hopefully many years from now, but if something were to happen to me, I am signed up to donate organs to somebody who needs it, and my family is aware of that, and they support that 100%. So US clinicians, I always ask you to advocate for blood donation and organ donation. I want to talk a little bit about airway management and COVID-19. This is one of my emergency medicine residents. He's a second-year resident. His name is Chris Nelson. Okay, Chris is very much like you. He's a little bit older than you, but at one point in his life, he was a high schooler, like many of you. He was a pre-med, like many of you. He went to undergrad, like some of you are right now. And at some point, he decided that he wanted to pursue it and apply to medical school. I am here to tell you that Chris is not only a bright, superbly intelligent physician, and it is no surprise he got into medical school, but he is also one of the kindest individuals I have the pleasure of mentoring and teaching as a resident, okay? Much like the other students that I showed you in the other picture, Chris has made tremendous sacrifices to be where he is today, and he is being rewarded by getting to be in the front lines, by having the privilege of serving on the front lines against COVID-19. And Chris has the privilege of learning medicine. And here he is practicing one of the main skills of an emergency medicine physician, and that is airway management, okay? On his left hand, he is practicing with a mannequin using a laryngoscope. It's called a laryngoscope. Is an instrument that allows us to push tissue out of the way, like your tongue, so we can get and see the vocal cords and the trachea. And he's doing that with his left hand. On his right hand, he's got the endotracheal tube, that blue thing that you see right there, and with the little green cap at the end. That is an endotracheal tube with a tube introducer, also a bougie, as we call it. And so he is moving the tongue out of the way so he can insert the endotracheal tube into the patient's trachea. Notice that he is not looking in the patient's mouth. He's looking to his right. He's actually looking at the screen. So modern medicine, modern airway management has us using some pretty cool toys. So his laryngoscope actually has a fiber optic camera at the end of it. So Chris can see what he needs to see by using the little camera there. When I was coming up as a young doctor, we didn't have these cool toys. So a laryngoscope only had a light, and you literally have to look in there with your own eyes. Well, now it's just a lot easier to actually look at a screen. It's nice and big, and you can see where you need to go. Okay. You'll also notice that Chris is using an acrylic clear box. Many of my colleagues in the early days of the pandemic in the city of Seattle, in the city of New York City, they were getting very sick with COVID-19 while taking care of patients. One of the things that we learned as a result of their deaths, we owe them a huge debt of gratitude for the lessons we learned, was that when you're intubating somebody, when you're in somebody's mouth, in their face, this procedure aerosolizes COVID-19 very easily, okay? And it is no surprise that the physicians were getting, and respiratory therapists and nurses were getting infected with COVID-19 at an alarming rate. Many of them died, okay? And so this physician in Taiwan invented this box. And basically what it does, it really minimizes the quantity of aerosolized particles that can hit your face and your body while you're intubating somebody. So one of the reasons I'm also showing you this slide is because part of what we do in medicine is sharing knowledge. We learn from one another, we share our knowledge, and research, for example, is something that's how we share the lessons we learn and impart them onto others. If this physician in Taiwan would have never shared this technology with us, God only knows how many more people would have gotten infected with COVID-19. Okay, so Ashna wants to know, is intubation the same as airway management? Airway management means anything that you do to control a patient's ventilation and oxygenation within the airways. Okay, intubation is one of those items as part of airway management. So airway management is kind of the bigger big umbrella, and then endotracheal intubation is one of those items that goes under that big umbrella. So thank you, Ashna, for your question. Julia wants to know, how often can a person donate blood? Okay, our blood supply actually gets replenished fairly quickly. So within a couple of weeks, you can actually donate blood again. Okay, so you always have to make sure that you check with your primary care doctor or with the donation center to make sure that you qualify, for example. But you can donate blood every couple of weeks. Okay, and the blood can be broken down into several parts: the packed red blood cells that we transfuse onto patients, the things like plasma, for example, and in COVID-19. Patients who have recovered from COVID-19 actually donate some of their plasma, which contains COVID-19 antibodies, and we can infuse those antibodies onto patients with COVID-19 to make them better a little bit faster. And then it also contains platelets, which helps us, patients who have low platelets, for example, blood donations help us transfuse platelets as well. Okay, so thank you everybody for your questions. Okay. Speaking of research, folks in the front lines, when we signed on to be physicians, we knew that no matter what was happening in the world, no matter what pandemic, no matter what situation, we were always going to show up to work and do our job. One of the ways in which we keep ourselves safe during COVID-19 is frequent testing and make sure that we're staying healthy. Okay, here you see me using swabbing myself. Basically, we were asked to go to occupational health every couple of weeks to check for the presence of active virus so that we could keep working and staying healthy, and also checking for the presence of antibodies as part of a research study to see how healthcare personnel like me on the front lines, how often we were acquiring it, what our antibodies were doing, etc. Okay, and we developed a very nice research study. It's called the Covered study. I'll put it in the chat before I forget, and you may want to take a peek at it. Okay. What I learned from being part of the Covered study, and after looking at the actual study results itself, I want you guys to take a guess for me. Out of all the COVID-19 tests that I put myself through with this swab, how many do you think came back positive over the many months of COVID-19? Take a wild guess while I take a swig of my water. Come on, don't be shy. How many do you think? Let's see. Any takers? Nobody wants to guess? Nuha says none. Okay, cool. All right. Less than 10% of the time. Thank you, Faith. Thank you, Nuha. Okay. The answer is a whopping 0. Okay. Well, here's where research comes in, and some of it is no surprise. Well, how does a physician, a nurse, a physician assistant, an EMT, a paramedic, a respiratory therapist who is actually working with proven coughing, short of breath COVID-19 patients, how can they stay healthy? Okay, well, very simply, the one thing that people fight about, a mask. What a concept, right? PPE, the thing that we put around our faces that we've been using for decades, for generations in healthcare to try to protect ourselves and to protect our patients. Wow, that actually works. Okay. I showed you the picture earlier on PPE. And sure enough, you wear your PPE, you're going to stay safe. Okay. But that is not it, ladies and gents. We also learned that people like me, we made a commitment that we were not going to take any chances with COVID-19. I have not set foot in a restaurant to dine since March of last year. I've not attended any indoor gatherings. Okay. And the only people who are allowed in our home, okay, and actually gather as a family is my family who lives here with me and my parents. Okay. We made a covenant at the beginning of this. We were only going to be allowed to see each other and gather and dine together here at our homes if we stay safe. I knew that if I take any chances and get myself sick and I got my parents sick, that would be unforgivable. The amount of guilt I would live with would be amazing. So people fight a lot about masks and it's my right, etc. But how about protecting others, for example? Ladies and gents, we've proven with our study, our research study, that surveillance is going to be very favorable for you if you just take care of simple things, simple public health measures. Okay. Guess how many of my antibody tests came back positive? And antibodies tell you that you've been exposed to COVID-19. Well, the answer, of course, is going to be 0 as well until I got vaccinated. Okay. A few days after my second vaccine, I took it upon myself to do my own antibody testing. And guess what happens? Well, that little test, and you can see it on my Instagram account. I have a picture of it, beautiful pink line showing IgG presence. So, and I have beautiful IgG coursing through my veins right now. Kids, the only way we're going to achieve the very coveted herd immunity is going to be by all of us getting vaccinated. Okay. I have spent a lifetime learning how to comb through the science and critique the science to make good clinical decisions for my patients. Well, when it comes to my health, I also do that. And I gave the vaccine all the critique that I possibly could. And the vaccine, in my opinion, is a safe, effective way of protecting myself against COVID-19. So get vaccinated as soon as you possibly can and always be an advocate for research. Let's move on to our very last case. You guys are doing phenomenal. This is a very unfortunate case, all too common during this pandemic. The case revolves a 45-year-old gentleman with a history of high blood pressure. He's had 2 weeks of progressive inability to fall asleep. And when he finally falls asleep, he's got difficulty staying asleep. Okay, so he stays up, turns on the TV until morning hours. He started suffering panic attacks and anxiety. And at some point, things got really terrible and he started developing thoughts of suicide. Okay. He became very desperate and came to our emergency department for help. When you interviewed him a little bit, he tells you that he lost his job as an insurance agent. He was furloughed due to the pandemic, and he was concerned too that his anxiety was being looked upon unfavorably by his employers. On your physical examination, he's got a flat affect, which means that he has not a lot of expression on his face, became tearful at times during your assessment, and he doesn't make good eye contact with you. So let's take a peek at what you guys think is the best next step in management. There's no wrong answer. Remember, we're just seeing what you guys want to do. Want to order a psychiatric evaluation. All right, cool. Sounds good. Let's see what else you guys think we should. Awesome. Some of you want to start him on medication. Some of you want to interview the patient. Okay. In the interest of time, I'll tell you that you know, on the very first slide, I told you that your main job as a clinician is going to be to ensure that service, sacrifice, and empathy lead the way each and every time. Okay. Um, we as clinicians have become, unfortunately, too reliant on, it's so easy for me to click a button and say, order psychiatry evaluation. Okay. All too easy to order a medication, send it to the pharmacy, go take your medication. And all too easy to click a button says discharge a patient. The lesson that I want to impart on you today is the following. Of all the things here that I put in front of you, all of these things are going to happen at some point. But the most valuable thing that I provided this patient on that day was my ability to show him empathy. What empathy means is the capacity, the ability for a clinician to connect on a human level with another human being without actually being in their shoes. I don't know what being an insurance agent is like. I don't know what being furloughed is like. Okay. I don't know what it's like to be him, but I can tell you this: empathy means that I was able to connect with him on a human level strictly because I am also a dad. I'm also responsible for feeding my family. And at the base of everything, we're both human beings. And I can only imagine the concern, the terror, and that he's got every day trying to think about how to take care of himself and his mental health while also being responsible for taking care of his family. So the most valuable thing that I did for him is sit down with him for 5 minutes to talk about his job, about his upbringing, about his family. And yes, I eventually got him plugged in with a psychiatrist to help him coordinate his care. Eventually, he got started on some therapy and perhaps medications. He eventually went home. So all these things happen. But the most important thing, guys, as a clinician, is going to be to connect with other humans on a personal level as best as you can. And trust me when I tell you this, it's going to be very hard at times. And you, no matter who you are, no matter what you tell me, you're going to lose empathy at some point. And I just want you to remember this talk when you can, because when you lose your empathy, just remember at the end of the day, this is another human being. It's somebody's father, somebody's son, somebody's husband. And if that were your dad or your husband or your brother, you would want them treated with empathy and respect. Just remember that. Okay. We're almost done. I wanted to tell you a little bit about working in the front lines is tough. I told you about the stresses that we go to, the decisions, the unfortunate cases, and kind of the difficult parts of being on the front lines. So how do we stay safe? How do we keep our mental health? I want to tell you a little bit about what I do. Um, Part of being a clinician is going to involve um, balancing the sacrifices, the long hours, the training, the disappointments, okay, the conflict many times that you have with things in your life that bring you meaning, that contribute to both your physical and your mental health. The first thing that I want to say is that the one thing that is the most precious to me in my life is my family. My family and I could have just decided, you know what, I'm going to go stay in a hotel because I don't want to get you guys sick. Or my family may have said, you know what, we don't want to get COVID-19. You're too high risk. You should go stay somewhere else and we'll bring you some food. That's not what happened. My family has supported me no matter what. And we said to each other, we are family and we're taking this risk together. We're going to stay safe. And no matter what happens, we'll be here for each other. When you have nothing else, no job, no money, no accolades, no car, no house, the one thing that you always will have is your family. Hang on to your family, love them, cherish them, sacrifice for them. They're the only thing that is true and constant in your life. Don't ever forget that. Without my family, I'm absolutely nothing, and there's no way I could have survived or be surviving this pandemic working on the front lines without my family. My physical and my mental health are very important to me. I have a few hobbies. I want to tell you about my favorite one, and that is cooking. I'm not a very good cook, but every once in a while, I cook something up that is actually very good. This was my Thanksgiving turkey. I learned a lot about cooking turkeys, and so I brined it, I basted it, I smoked it, and I am here to tell you this was the best turkey that I've ever had. And the proof was in a completely empty carcass when my family had plowed through it. Okay, what I like the most about cooking is the strategy. I like the process of it. I like the preparation. But what brings me the most happiness and the most joy is seeing how much my family enjoys what I cook. That brings me a lot of meaning, gives me a good distraction. My favorite distraction, however, is something that brings me both physical and mental health. And that is my cross training. I cross train 4 days a week, sometimes five, depending on the week. I do Camp Gladiator, which is cross training. It's always outside, and no matter if there's rain, snow, shine, heat in the summer, we're out there, my teammates and I. By the way, we've had zero infections amongst my teammates because this is all outdoors and we remain distant. So if you want to stay safe and still be active, do it outdoors each and every time. Okay. My cross training brings me structure. It brings me camaraderie. It allows me to get away from kind of the day-to-day grind, and it helps me to focus on something that is kind of physically demanding, and allows me to push my boundaries. Okay. I am very happy to tell you that sometimes, like through weird twists and turns, these turn into very productive things. And one of the things that happened here recently is I became a sponsored physician athlete for Circle Water. Okay. I'm very, very happy to do that because I've put in so much time and so much effort toward being a physician and being an athlete and being recognized for it, by a product that I actually use every day. That's amazing. So they sponsor me. Okay. I share that with you because you need that balance in your life to work as much as I do, and I work a lot, and the stress is very high. Okay, so I just want you to remember you need that balance in your life, and you don't have to be an athlete. You don't have to be a cook. Find things in your life, especially later on in life, that bring you meaning and structure, that allow you to stay mentally healthy. And the most important thing about this, guys, is that when you're struggling with your mental health, it is perfectly okay to seek help. We got to destigmatize mental health disorders. And I will be the first one to admit that I have sought help before when things got tough. Okay. And I'll share it publicly and I'll scream it in the mountaintops. You should seek help no matter what. All right. I serve as the medical director for a virtual clinical observation program. I designed this program to be a little bit different from kind of what's out there, kind of a PowerPoint based deal. So what we do is we have standardized patient encounters, physician and patients. We record them, we show them to you, and we abide by the American Association of medical colleges, the competencies. So we don't just tell you about clinical cases. We also discuss competencies that are important, like professionalism, team dynamics, conflicts, how to have a difficult conversation with a patient, delivering bad news. So the clinical aspect is great, phenomenal, but I think, to me personally, the most important thing is the other part of it, of being a clinician, is the communication aspect, your team, those dynamics, how they work. To me, that's really important. Okay. Some of the best clinicians in the world master this aspect of things. They may be really good, um, may do really good therapeutics, really good diagnostics, but the clinicians in my life that stand out the most are the ones that are excellent with empathy, communication, leadership, etc. And some of those skills we also promote in my program. We also do rapid fire cases. and we do an extensive Q&A, and we actually allow live questions for the encounter. They're an hour and a half on the first Thursday of the month. And some months we're going to have 2 sessions with some fun things in there. Like, for example, when my dad had his heart attack, I did a lot of documentation, take a lot of pictures, and I'm happy to announce I'm going to have a session focused on my dad and his journey, and he may or may not come over for that session. So this is my Instagram account. I post almost daily content and pictures and quizzes, etc., for all pre-healths. And this is our this QR code. If you've never dealt with it, you put your phone camera to it. It should take you to our website. And on my Instagram, there's a link to the registration and payment for the program. We opened that up yesterday, actually, and the payment doesn't go to me or my pockets. It goes toward paying for a learning management system where you can watch prior lectures, you can print certificates, you can look at our library of content, and it's a nice place for you to have your own login, etc. And it's your baby. That's where your money goes. So thank you so much for that presentation. Thank you for having me. Thank you for your engagement, and give me a follow on Instagram. So it is time for questions, guys. Bring them.
Hey guys, thank you so much, Dr. Salazar. You really explained the COVID-19 so well, and I think we all learned something new. So moving on to all the questions you guys gave, we're just going to be going through the questions you submitted through the Google Forms. And if you have more questions, feel free to put them in the chat now. So the first question we have is, what are your regular work hours like as an emergency medicine physician? And did they change when you were on the front lines?
Yeah, as an emergency medicine physician, as an academician, remember I have a couple of jobs, not just clinical, but also academic, educational, etc. So for example, when I'm working clinically, those are 9 hours, like actual clinical work, okay? So I'll see patients for about 8 hours or so, and then leave an hour for documentation, etc. And I do that several times a month. Then that's about 50% of my time. The rest of my time is through educational activities with the fire department, with the EMS training programs that I run. A good chunk of my time is teaching our residents, teaching medical students, for example. And so that is about 50% of my time. Do I work 40 hours a week? Heck no, it's a lot more. It's a lot more than that, but it's pretty variable how much above 40 hours. Some days I'll work upwards of 70 hours, guys, sometimes 75 hours. Okay. And being a good organizational manager of your time while taking care of yourself and of your family and of your patients is really important.
Yeah, that's a lot of work, but thank you for your service. It's really important. So moving on to the next question. So for others that kind of want to go down this difficult career path, what was the hardest part of becoming an emergency medicine physician?
It's a phenomenal question. Remember that when you're in high school, when you're in college, you don't just go to school with pre-healths. You go to school with many other folks with other backgrounds, with other interests. One of the hardest parts was that, especially after graduating from college, the majority of friends go off and they get jobs. They start having families. They start buying a home and a car and earning a paycheck. When you're a pre-health, a pre-med particularly, you're actually paying to go to school. Okay, so you're dirt poor for many years. It's crazy, right? To actually pay to work in medical school, to get your butt kicked, and you sacrifice a lot. Okay, even as an undergrad, even in high school, guys, when a lot of my classmates would be on a Friday or Saturday night partying or going out or at the movies, I wasn't with them. I was at home. We're plowing through the books, my brother and I. Okay. Same thing in college. Oftentimes you would find me in the library being the one who had to be told that we're closing the library on a Saturday night. It's time to go home. Okay. That's really hard. It can be socially isolating often. It doesn't have to be that way, but oftentimes you're going to feel kind of the pressure. It's like, God, man, like I'm getting my butt kicked. And it's really hard, but it's part of being, part of putting in your time, making that sacrifice. And in the end, it's all worth it.
Thank you. I think that applies to a lot of us here. We're going down the same path. And going off of that, how do you deal with the stress that comes from your job and in your day-to-day life?
I mentioned a little bit about balance. People use the word balance way too often. So I'm going to try to dumb it down for you. For every ounce of effort that you put into your work, no matter if it's clinical or educational or didactic, you gotta have an equal amount of effort, an equal amount of ounces of taking care of your mental, physical health, and your family. Okay. The most important skill that I learned over the years, kids, is the skill that it's the hardest to learn, and that is how to say no. When you're very young, you're hungry, you're a go-getter, you want to get your hands in everything in the world, seems like you want it at your grasp, until you realize that the more things you get into, the less of a better job you do with each of those things. And then you learn later on in life, when you get some gray hairs like me, that it is okay to say no, and you can dive into a few things and be really good at those things. Okay. So I learned to balance my career very well by saying no often, diving into things that are important to me, getting really good with those things, and balancing those with an equal amount of energy into the things that are important to me outside of work.
Yeah, I think that was great. I think a lot of people think they're going to struggle with balance. So thank you for your tips about that. And I think we touched a little bit on like what's the most difficult part, the difficulties of being an EM physician. But what do you think is the best part about the job in general?
On a day-to-day basis, for me personally, going to work is a social experience. In many specialties, I feel, it's my humble opinion, that people look at a career in medicine and then just go to work and just crank it out and come home like it's some kind of workout or something. Okay. What I like the most about emergency medicine, what I like the most about where I work, what I like the most about being an academician is all encompassed into one thing. I get to go to work with some of the most talented, genuinely human, funny individuals I've ever had the pleasure of knowing. So the environment is stressful. It is difficult, but what better way to be in the front lines and going to battle with people that you absolutely love? Dr. Fowler, who many of you know from virtual shadowing, he is my colleague. And my relationship with Dr. Fowler is not just colleagues. It's not even just friends, guys. Ray Fowler and I literally have a father-son relationship. Dr. Fowler doesn't have kids. He calls me his son, okay? And I treat him like my dad in many ways. When you have that level of love for the people you work with, that makes it all worthwhile. So imagine going to work with people like this every day. To me, that is my favorite part.
Awesome. Yeah, I definitely think the community around you is super important, especially in a job like this. Jasmine is asking, did you consider any other specialties besides emergency medicine? And how do you stay motivated? Which I think you did talk about a bit.
It's okay. Thank you for your question, Jasmine. When I was a first and second year medical student, I started learning a lot about family medicine. I loved the lifestyle of actually building relationships with patients long term. That's not something that I have in emergency medicine with my patients. I loved the fact there were jacks of all trades, just like an emergency medicine doc is. And so I was very heavily involved. I was even an officer for our kind of national program for family medicine. As a second year, I went to the national conference, etc. So I was really deep into family medicine for a time, but then I saw the light. A quick funny story about emergency medicine. I had always had an interest in emergency medicine based on a show called Trauma Life in the ER. Just watch old episodes on YouTube. They're phenomenal. Trauma Life in the ER. Some of those took place at UT Houston, which is why I decided to rank UT Houston 1, by the way. But my passion for emergency medicine happened on one evening as a third-year medical student during our OB-GYN rotations. As a medical student, you would be on call for 24/7 every 3 days or so. And on one of those calls, one of the residents that was also on call with us was an emergency medicine resident. Okay. I'm not going to say her name, but she walked in and there was something about, she was wearing her white coat. There was something about her name, MD, and underneath emergency medicine. And I don't know why or how, but I fell in love with the concept of emergency medicine based on her jacket. Don't ask me why. It's dumb, I know, but there was something really, really special about it. And once I started learning more about emergency medicine, I realized that was fit my personality the best. So it was her white coat that actually got me hooked. How do I stay motivated? Guys, one of the reasons I'm doing this lecture today, um, this is my way of paying it forward. Just like I was afforded the opportunity to be a physician through the kindness and generosity of many people, this is my way of paying it forward. Okay. Being here and paying it forward, giving of my time to me keeps me motivated. Getting to know people from other walks of life, people different than me, younger, older, keeps me fresh, keeps me vibrant, and always hungry. So that's how I stay motivated.
Yeah, that's great. Thanks for your tip. And one of the last questions is, would you encourage students to become EMTs during undergrad to help them understand the medical field better? I think we touched on this in our previous seminar, and people were wondering if it would be a good choice to take that up.
Emergency medical technicians, EMTs?
Yeah.
Okay, cool. All right, I'm going to say something a little controversial. Okay. I think a lot of folks look at being a pre-med and applying as a series of check boxes they gotta have. And they just want to kind of check those boxes, put in their application, and kind of hope for the best. Okay. I'll be very frank with you. The people that I want working with me, my trainees, my students, they gotta be first and foremost committed to service and humanism. Okay. So some of the best applications that I've ever seen for medical students and for residency are folks who have gone on to I'm not a big fan of seeing like an application with 30,000 clubs, 30,000 activities, and volunteer hours and shadowing. And then when you ask them about something, they can tell you very little about it, showing very little commitment to it. That doesn't show me that you're committed to humanism and service. Some of the best applicants over the years have been folks who have gone on to do something not even medical often, okay? Like service oriented, like folks who started an organization to deliver food in a food pantry for elder folks. And when you ask them about it, they can tell you everything there is to know. They pour their heart into it. That's the kind of folks that I want to work with. Okay. Will an EMT certification give you medical background and experience? Yeah, it sure can. But I don't want you guys to do it just to check a box. I want you to find something that is absolutely meaningful to you, that exposes you to people, to being of service and humanistic and learning empathy, not just to check a box. To be frank with you, a lot, if not most, of folks are coming into medical school now with their EMT certification. And now when I personally see it, I'm like, okay, cool. But what are the things that make you special? Is being an EMT in it and of itself make you special? I don't know about that. Okay. Last thing I'm going to say that's controversial. I am beginning to firmly believe that medical missions as abroad, overseas, as a way of kind of checking off a box, to me, it's becoming painfully obvious to me that probably is for the privileged. Okay. If I was a pre-med, there's no way I could have afforded. My family couldn't afford to send me to Africa or the Middle East or Southeast Asia, or even Central America to volunteer. Okay. So does 2 weeks in, say, Tanzania, does that really make you a really good clinician? My answer is probably going to be no. Does that really make you a better applicant? My answer is probably going to be no. So I didn't get to do it. I was actually involved in things here at home in my community. I'm going to just encourage you guys, like, if you really want to be of service and show me humanism, do things within your community, the people that need you the most, right here, right now. If later on in life you want to be like Walt Green, one of my colleagues, and goes to Central America to give of your time, great. But don't do things just to check off a box, that hoping you're going to impress somebody. You really want to impress somebody? Freaking show me that you really care about human beings when it's really, really tough, when they're angry with you, when they're at their worst, or hitting you, or when they're covered in feces. Show me what you got. Okay. So yes, that EMT certification, will it help you? Yeah, it'll give you some exposure, but do things that are actually meaningful, that give you meaning, that are personal to you. Hopefully that answers your question.
Yeah, I think that was a great answer. It really did hit a lot of great topics. And we just got a question in the chat, and they said, is residency as harsh as it seems on TV?
I assume that I don't know if we're meaning like fictional shows, or you've seen shows about residency, but I'll tell you this. Many years ago, residency was almost a little malignant. Okay. A lot has changed about residencies now. I think I belong to a generation where residencies began to really understand and realize that resident physicians needed to be protected. They needed to be mentored. They needed to be guided, and that abuse in terms of hours or interactions were not going to be tolerated. But many years ago, it was. Okay. Did I work 80 hours sometimes as a resident? You better believe it. Okay. Do my residents now work 80 hours sometimes? You better believe it. But the things that have changed are the ways in which we help them take care of their mental and physical health, with mentorship, with making lifestyle easier. How much remote and virtual learning can we do to allow them to be home with their families, etc. We monitor their work hours very, very carefully. Okay. And we have a zero tolerance policy for verbal and even physical abuse for residents, which sometimes was present. You can, Dr. Fowler has stories about that. Okay. So is residency tough? Yeah. We expect a lot out of you, but it's not for the reasons that a lot of people think residency, that associates malignant residency with, if that makes sense.
Okay, thank you for your question. I think that's it. So thank you so much, Dr. Gill, for giving us this presentation and answering all the questions that our participants had. If anybody has any last minute questions, you can drop them in the chat and we can see if we can answer them. Or you can either message us at Advocate for Lives or Dr. Gill at his Instagram on the slide, and we can answer them then. So for the participants, make sure to fill out the form that will be posted on our Linktree in order to receive your volunteer hours. And as we mentioned on the post, if you get over 50%, a certificate will be sent to you by email. So overall, thank you guys so much for attending this seminar. I hope you guys learned a little bit of something and have, I think, a bigger appreciation for the doctors that work at the front lines during this pandemic. Remember that we have seminars lined up every Saturday for this month. So follow us at Advocate for Lives to get more volunteer hours and learn more about the healthcare industry in general. And thank you so much for this presentation.
You're so welcome, guys. Thank you so much for having me. It means a lot. And I really do mean it when I say stay hungry, stay humble, and service to others with empathy is the only way to go. I'm really proud of you guys. So thanks for having me. I'll stick around for a minute or two, say our goodbyes. And if there's no further questions, then I'll go do some more housework.
So if you guys don't have any more questions, you are free to go, and we hope you come to our future seminars.
Thank you so much, guys. You all did a phenomenal job. I really appreciate you.
Thank you.